care. And we learned from the support study the common trajectories that we were seeing. And again, you've heard the theme of this, that if one is to look at death from cancer, and here is the model of colon cancer, and this comes directly from cases in the support study, that with cancer, for the most part, there's often a trajectory of a period of time of stability, and then a rather more sudden drop-off leading to death, often within 6 months to a year. In contrast, with diseases like congestive heart failure, there are episodes along the course of the illness that make someone look like they're dying, but then they are given diuretics, or they're intubated, or they're put in an intensive care unit, and they get better, and the course is much slower. And these are the chronic illnesses, congestive heart failure, that we're talking about, which would be, I think, a good model for the construct of chronic progressive disease. So we've identified these different patterns, and we need care systems that would be able to address those patterns. But the difficulty was, in the United States, if you had cancer and you could identify that you might be dying in 6 months, you could receive hospice care. But if you had congestive heart failure and no one was willing to identify that you might die in the next 6 months, you could not receive hospice care. So immediately we had a care system that was focused to provide care to certain groups of cancer patients, but not to non-cancer patients. This is now changing, but this was the state in 1995. Again, as part of our project, we wanted to create a national discourse. We wanted to really get the public talking about death, because it was a taboo. And so we had a variety of efforts with multiple foundations to encourage this kind of death discussion. We also were very much supporting the development of undergraduate and graduate education programs in pain relief, in palliative care, to be able to broadly educate physicians. And this death talk included enormous and increased public awareness. Encouragement by the TV programs, by radio programs and magazine coverage to talk about these issues. The Robert Wood Johnson Foundation put on a campaign that was called the Last Axe Campaign, and created enormous educational material for the public about what their choices are as they were dying, what information they might have, how to have specific conversations. And then in a most incredible 4-part series that is still available, it's available on websites, can be easily downloaded, was a series of more than 6 hours of a television program in which more than about 30 million Americans watched this program on television, where there were open discussions with patients and with families about what does it mean to die and how one might think of choices, how one might talk about this with one's family, how one might write advance directives. So a broad, engaged public educational campaign. And the Robert Wood Johnson Foundation supported libraries around the countries to have group discussions after these series were done, to be able to convince Americans to have a better understanding of what their choices might be as they were dying. And there were multiple educational websites developed. The importance, I think, of the Bill Moyer series, more than any other, was it engaged the public in a very direct way and was a very powerful force. Some of the TV changes was that we worked with the producers of programs like ER to be sure that they better portrayed hospice care, pain management, and palliative care, and breaking bad news in their programs. And in fact, one could see the evolution, particularly in ER, of significant improvements of how this TV drama changed over a period of time with the input of a variety of experts explaining to them what was palliative care. So we were very much at the public awareness piece. And lastly, to really provide competent, compassionate care, we needed to define a better reimbursement system for end-of-life care. And in all of this, we thought we could transform the culture of death and dying in the United States. I'll tell you now that we've not transformed it. I think it's better. I'll give you examples of how it's better. The support came from the Soros foundations, and we were totally independent of them in the sense of being able to fund whatever we wished to fund without any input from Mr. Soros, who personally believed in the care of those with severe, serious, advanced illness, that they had and should have the opportunity to be cared for at home. They have the opportunity to remain with their families, and that the care should be competent, and that patients should have choices in care. And so that was the support that he had seen given to his mother, and it was something that he felt every American should have, and now supports palliative care internationally. We decided a very elite strategy, and so we thought we needed to convince those who were probably the greatest problem in advancing palliative care, and that was the medical establishment. And so through our Institute of Medicine, which is a very influential and again elite academic group, we had 3 reports that we supported, which began to define for the healthcare institutions and leadership what were our problems. They each, again, are on this website. You can download them. They're really excellent descriptions of how we should think about and come up with recommendations for improving the care of the dying. But each of them said in the beginning that we've identified the enemy, and the enemy is us, meaning the healthcare professional. And it was the lack of knowledge of physicians, it was the lack of training of physicians that were leading really to both not compassionate care and incompetent care. And so it placed a heavy burden on the healthcare institutions and healthcare leaders to begin to change this problem that we were having in the United States. And these are the 3 reports, and again, as I've said, they're readily accessible to you. They very strongly came out and said, with an evidence base, that end-of-life care in the United States lacks compassion and competency. Those are pretty strong words, and they were told to the public. That healthcare professionals lack education and training, that the public lack information on choices in care, that research in palliative care is not a priority, and that pain, psychological distress, is both underassessed and undertreated. So it identified these major components and have been very influential in beginning to guide new approaches in medical education and training. One of our major efforts was to think about, well, how do we change medical education in the United States? Well, often the best way to change it is to begin to is to support leaders. And so we created a faculty scholars program. And over this period of time, we funded 87 faculty scholars. These are young leaders, physicians, public health, physicians with expertise in public health, with physicians in primary care. We funded 1 lawyer in this project. And then we created a leadership program in social work as well as a leadership program in nursing. And now we are almost 15 years out from the beginning of this project. And what we're seeing is that these very individuals are the leaders in the country. They are the chairs in palliative care. They are the major contributors to the literature. They are the major grant-receiving recipients. They've been quite an extraordinary group. So leadership does make a difference. And they were based all over the country, so that we had them in rural states, we had them in northeastern states, we had them in academic institutions. But they were all in institutions where they could be influential in being leaders in advancing palliative care in their hospital, in their university, in their city, in their community. And this type of leadership has been very, very important to influencing the ability to train physicians and nurses throughout the country.